So just before I turn it over to Corey, I just wanted to sort of give an idea of what Audacious Inquiry has been helping us take a look across the spectrum of arrangements that are allowing disparate organizations to connect and exchange data. And you've heard from a lot of them today, and Corey is going to share with us what they have been able to see sort of as the aligning areas and the places where there may be some gaps in there. And that'll really be the work that we need to do moving forward on 21st Century Cures.
Great, thank you, Lee. So, you know, as Lee mentioned, we've talked to a number of these organizations. We've looked at the trust agreements and various documents that make up the work they do, and are going to be providing a high-level overview of kind of where we see the alignment and differences across the work they do. I think you're going to hear a lot of common themes from some of the things we heard throughout the conversation so far. I definitely heard a lot of the things that I was planning to talk about. So, you know, you will definitely hear those common themes throughout this conversation. In this presentation. So first thing I think is really important to highlight across these organizations is they were all established and have different goals, purposes, and the scopes that they're focusing on, right? You know, I think we heard a lot of overlap in what they do in the areas they focus on. But you have to remember, you know, each of these organizations was founded at a different time by a different set of stakeholders for a different purpose. So that drives some of the differences across how they're organized, how they've created their, you know, arrangements and, you know, legal agreements and technical approaches. So it's just really important to keep that in mind. Some of these organizations were really developed at different times in the industry and the ecosystem and where things were from a technology perspective. So that drives some of the differences across their approaches. You know, one other thing I would highlight is, you know, across this, you really see, you know, each of them has created this, you know, fabric of trust across how they operate. And each of them has created, kind of taken different patches of a quilt to create that fabric of trust that they've then stitched together. So a lot of these organizations rely on contracts and legal agreements as one of those components. There's, you know, some use self-attestation processes. A participant says, okay, here's what I do. You know, it says, these are the steps I take, and then you have to provide some documentation. Others have an accreditation process as a part of their kind of quilt. And some have technical, you know, formal technical testing programs. And we'll talk about a lot of these themes in more detail throughout the presentation. But again, the idea here and the kind of key point is that these organizations have different approaches that they've taken to stitching together what enables exchange across their network and their kind of approach. One of the other kind of differences you see is each of them has a different set of infrastructures that they potentially operate. Some have a lot of infrastructure they operate, some have a little bit, and some don't really operate much of any infrastructure to really facilitate the exchange of data amongst their participants. So just, again, another one of those areas where you see differences across. And the other thing I think is really important to keep in mind, and you definitely heard this point throughout the discussion this morning, is all of these organizations have processes and approaches to evolve what they do. So add use cases, add to their kind of legal and policy agreements, and add to their technical approach. These aren't static networks that were developed, you know, in recent years. They're all looking at, you know, the evolving needs of the healthcare ecosystem and evolving their approach to align with that. And I think you heard that a lot in the conversation this morning. So the one other thing I would just note is, you know, they all have structures, again, like I was talking about, to govern that process of evolving their network, and also for kind of enforcing the rules of the road that they've established through their network. So oftentimes it's the board of directors or some sort of steering committee. Usually they have some sort of set of subcommittees under that help drive, you know, the priorities and evolution process of these organizations, but also enforce the rules. And again, we'll talk about a lot of these themes in more detail throughout this presentation, but those are some of the kind of high-level pieces. And again, you know, it's just really important to keep in mind that these organizations have different purposes and scopes. A lot of them, I think, as we heard throughout the conversation, are focused on enabling the information to move across their participants to support clinical care use cases. But we also heard there's organizations focused on ensuring patients can get access to their information and kind of become the center point of care. So again, these differences in what you're trying to drive forward and enable and your goals drive differences across what they're doing. All right, so one of the key areas you see difference across these organizations is around the permitted purposes that data can be used for. So kind of a common theme across a lot of these, and where a lot of organizations that try to enable exchange started was for treatment use cases, right? So I think if you look back in the early years of health information exchange, you're going to see most of these organizations were founded, and what they were focused on was enabling information to move for treatment purposes, sometimes only, right? Like that was the goal. That was the area everybody felt like they could bring stakeholders together, and it was hard to argue with moving information for treatment purposes. That's definitely evolved over time, and I think again in response to building trust amongst the participants. But also just in the evolution of the needs of stakeholders to get access to information. So you've seen it move from just treatment purposes to broader use cases, public health, operations use cases. It really has kind of changed across the board. And I think you see that in the organizations that we're presenting this morning, right? Some of them started more focused on treatment use cases. Some of them have broader sets of use cases. You also see different approaches to how they kind of address establishing permitted purposes. Some set a kind of broad, here are the permitted purposes for which you can exchange across our networks. And that's just, kind of the baseline layer. That's what it is. Others try to articulate it by use case, right? So here is the kind of broad umbrella of permitted purposes for data, and then by use case outline, okay, here are the kind of permitted purposes for this specific use case. Again, falling under that broader umbrella of we've established here are the permitted purposes for data use across our network, and then by use case outlining differences in what can be done. And you also see different kind of requirements tied to those different permitted purposes. So sometimes you'll see requirements for reciprocity around treatment, the exchange of data for treatment purposes, that if you're going to send or ask for data, you're also going to have to do both ways of that street. And sometimes those requirements don't fall on other permitted purposes, for instance. So again, just one of those important things to keep in mind. Another thing to highlight here is the different these different kind of trust arrangements that we heard from this morning have different participants that are bringing in different data that can be exchanged. So sometimes you see just clinical data as part of their network, sometimes it's clinical and claims data. So those sorts of differences in the data that's actually residing and able to be exchanged across these networks just drives some different decisions and differences is across these networks. And I think that variability in permitted purposes and data that's available drives some of the kind of differences and challenges. I think when you look back a couple of years ago, when a lot of organizations were initially, outside of maybe these trust arrangements, trying to establish exchange, one of the key areas you saw of concern was different permitted purposes. If I just allowed, if I didn't allow payers to access data in my network, and I wanted, I was talking to a network that did allow that, that was a key kind of conflict point. And these trust, these arrangements that we've heard from this morning have really worked to kind of even that out across these organizations and develop a place where they're comfortable exchanging with each other, even where maybe the underlying networks have different permitted purposes that they allow, but they say, all right, here is the set of permitted purposes we're going to allow, to exchange data within our kind of broader network. So closely tied to that is the set of participants that are allowed, the permitted participants in an arrangement. See why people had trouble with this. So this is another area where you see differences in the arrangements. A lot of different organizations potentially participating, from providers to payers, government agencies, health IT developers, and so on. So different networks have different set of participants, and that drives differences. I think you heard examples from the conversation this morning. Sometimes, for instance, government agencies have different sets of policies and requirements they have versus some of the other participants in the exchange network. So there's examples where there are different sets of policies being set up to exchange with government agencies. Sometimes you also see exceptions in requirements for government agencies. So for instance, sometimes government agencies are allowed to only, are allowed to just query for information and not have to be a responder, whereas all the other participants in the network have to do both, potentially. So again, you just see that variability by the set of participants that are tied to it, and that drives differences across these networks. And again, this also, kind of the set of permitted participants and the kind of concern that can come up sometimes across exchanging across these different networks. It's also closely tied into the set of permitted purposes that data can be used. So these areas are really kind of joined at the hip a lot of the time when you see concerns across networks for exchanging health information. So the next area, and we definitely heard a lot of conversation around this, is around identity proofing and authentication. I think, as has been articulated throughout this conversation, a longstanding tenet of moving health, exchanging information, whether it be in healthcare, banking, or any other setting, is that I need to become, confident that the organization I'm exchanging information with is who I believe they are and who they say they are. I think historically, with the fax examples and others, it was more of kind of a local arrangement. I knew the doc down the street that I was sending information to, but these types of organizations are trying to enable interoperability at a national scale. And there's no way you're going to know every doctor that you're trying to exchange information with when you're looking at the national scale. So each of these organizations have developed their approach and kind of their bar that has to be met for identity proofing and authentication. One of the things you see, while there's frequently kind of a common, technical or policy approach taken to it, a lot of these networks rely on digital certificates, for instance. But the underlying policies that they've attached to those digital certificates vary. So while they may be using the same set of technology, they have different sets of policies that underlie that. So even though you have the same technology, you have different requirements. So therefore, the trust doesn't work there. And it's not necessarily going to drive that interoperability, because all these networks have set different bars of where they think these need to be at to be confident that they're exchanging with other people that are meeting their identity proofing bar or their security bar. And I think, a few years back, one of the things you often saw as networks were sitting down and trying to talk through this is that they would have different bars for these things, and they'd say, well, I don't want to exchange with you because my bar is higher than yours. And there was just that lack of comfort. So again, this is an area where these organizations, these arrangements are working to get their participants comfortable and setting a bar that they're then confident in exchanging with. So so you see varying technical approaches to enabling exchange across these arrangements. So sometimes you'll even see for instance, where they're enabling a query exchange. While they'll often be using similar standards, they may have different implementation guides or different technical infrastructure that they're enabling to do this, which then would potentially make, if I'm participating in one network, it's not necessarily going to be the same set of standards or infrastructure that I'm going to need to work with in another network. So it drives that variability across them, even though they're, oftentimes using similar technical standards or implementation guides. The other thing, I think, where you see a lot of difference across these networks is in the technical infrastructure they provide. Some provide a more robust set of, here are the services, everyone is using this, everybody has to use it as part of our network. Sometimes you see optional services that can potentially help with workflow or make it easier to find information. For instance, having a network of participants that it's optional to participate in. Anybody who's using that can then get access to all the endpoint information for all the other participants in that, but it's not necessarily a required part of the network. You also see things like record locator services or other services that are optional components, but again, kind of ease the workflow and the ability to find information, but they're not required elements. So you can participate in the arrangement and not use those particular parts of the technical infrastructure. And I think the other thing that comes up in this, right, and I think we heard it this morning, is different technical architectures. Some of these networks are more centralized, and everything flows through central points, a central set of technology. And sometimes these arrangements are more federated, and there aren't necessarily any central infrastructure or points where the information moves through. So those are just really important considerations, right? I mean, that is part and parcel to how these arrangements have been developed, and it drives a lot of different things around what you can do from a technical perspective, what you can do from a measurement perspective. So it's just important to keep these things in mind. It's not that one approach is better than the other, but the goal of this analysis is really to point out, here's where we're seeing similarities, here's where we're seeing differences. Because if you don't understand the landscape, it's really hard to kind of really think through what's actually happening out there. So one of the other important aspects, I think you see a lot across a lot of these efforts, is efforts to address cooperation and non-discrimination across participants. Most organizations have policies in place to prevent participants from adding on additional legal agreements or other kind of steps or processes you have to go to enable exchange with other participants in the arrangement. So for instance, I can't say, all right, we're both part of part of this arrangement, I'm going to require you to sign another legal agreement to exchange data with me. You know, they're specifically set up to say, here are the rules of the road, everybody's agreed to these. You shouldn't be able to put any other technical or policy barriers or hoops that folks have to jump through to exchange with one another. Now you see that kind of approach to doing that, you know, varies. Some it's just you can't do additional legal agreements. Sometimes there's no additional testing requirements that are allowed to be put in place. So again, how these arrangements operationalize this varies, but it's a common component you see across a number of them, really to, you know, because the goal of these organizations is to enable data to move across one another. So they want to try to eliminate as much as possible any barriers that participants could try to erect to that. And the other thing you see across some of these networks and some of these approaches is provisions aimed at preventing discrimination across, you know, and attempts to discriminate against participants. Again, similar to the idea of preventing additional kind of legal or policy or technical barriers to exchange, some of these arrangements have set up policies that say, all right, if you're going to do this, if you're going to participate in this use case, and you're going to exchange information for treatment purposes, you have to do it for all participants, anyone who's participating in this. You can't decide, all right, I don't want to exchange data with the hospital down the street, but I'm willing to exchange it with the one across town. There are a lot of these arrangements have put in prohibitions, so you can't kind of cherry pick who you're exchanging with. And I think a lot of that's built on kind of the lessons of the past and the challenges that have come up in these sorts of efforts historically. So I think you see a lot of lessons learned, and I think we heard some of that from the discussion this morning. So really, again, the key points here are trying to drive the limitations on additional barriers that can be put up and additional steps you have to take, and also thinking about how do we ensure a consistent approach to exchange across different use cases and different permitted purposes. And again, you see these arrangements kind of doing this in different ways. Sometimes it's based on specific permitted purpose of the data, whether you're allowed to erect additional barriers or have that kind of requirement around exchange or not. So the most, you know, one of the key elements of this, and I kind of think about accountability on two prongs. You know, obviously for any of these arrangements to work, everyone who participates in it has to be confident that all participants are following the rules of the road, following the technical approaches, and they have that confidence that I'm not the only one adhering to these sets of requirements. So all of these arrangements have processes in place for accountability, and you see a lot of variability across these organizations, right? And they set different bars, and you got to think about, you know, each of them has set their bar that their participants are comfortable with, but they're balancing the kind of level of effort required to meet that bar. So you see, again, there's different approaches that have gone into this. So, you know, we talked a little bit about this at the beginning of the presentation, but you know, some organizations have lightweight self-attestation process, right? So here are the set of requirements. I look at it, I provide documentation that I'm meeting these requirements. That's where some organizations have set their approach. You know, it kind of goes from there to, you know, robust, independent, third-party, whether it be accreditation or certification processes that provide a higher bar of assurance that, okay, any participant in this network is meeting this set of requirements, and they have to go through that third-party process to do that. So again, you see a lot of different approaches to this. You see technical attesting requirements. Sometimes that's a kind of a certification program that you have to meet these specific technical bars. Sometimes you see participant testing requirements that could be pre or post-production, really to kind of drive that endpoint-to-endpoint exchange, make sure the interoperability you're trying to enable is actually being enabled across your work. But the other piece of this are around the accountability, right? There's that kind of upfront piece of, all right, we need to have a process in place to provide our participants assurance that everybody is meeting this requirement. The other side of the accountability, obviously, is enforcement, right? And what do we do with bad actors or organizations that fail to meet some of these requirements, maybe not intentionally, but they're still not meeting the set of rules of the road and requirements that we have instituted. So all these organizations have enforcement processes to address that sort of situation. They also have dispute resolution mechanisms that they've put in place to address, you know, disputes amongst their members. For the enforcement side, you typically see it roll up to whatever the board of directors or kind of high-level governance body of those organizations are. to make the kind of final decisions around, all right, what are the consequences going to be for this violation? Is it you're suspended from the network and you have, X number of days to remediate the problem, or is it you're terminated from the network because you violated the set of rules? So again, kind of the details of what those look like vary across the organizations, but all of them have processes in place for holding their participants accountable, for enforcing the requirements and addressing bad actors or those who violate the set of policies. And then the last piece of this, again, is that dispute resolution process, right? So sometimes the participants in a network are going to have different perspectives or run into challenges. So all these organizations have established dispute resolution processes that really, try to initially at least bring the two parties together, have them kind of meet, address those problems. And if that first kind of step fails, they all have different approaches, whether it be mandatory arbitration, taking it to courts. Those aspects of it vary across the organizations, but they all have kind of similar overall processes to address the kind of disputes and variability across what these organizations do. So that is our high-level overview of what we see, the variability across these organizations. I think as we move forward, we're going to be doing more work on this, probably providing more detail in the future. But at this point, I think at this step in the process, we wanted to provide this kind of high-level takeaway across the organizations in the areas where we see alignment and differences across them.
Thanks, Corey. So we're going to have about a 15-minute break, and when we come back, we're going to have a public comment section of the agenda. We're going to actually open with the online public comments. We're getting quite a few in, and we are cataloging all of those. We did not want anyone participating on the webinar to feel like they are not getting equal footing with folks in the room. So we'll start with the online comments first. So we'll meet back here in about 15 minutes at 2:25.
Sorry, I'm an officer of public health. So, Andy and I. Yeah, I know Andy is strong, man. I know Eric. Well, I work with him. This is
I knew you like hospital. You're not too much Oh no. The thing is that nobody's going to comment on anything. They're just thank you for your. We will read it. Read it, but we cannot. They're not. Nobody's going to answer anything. Yes. But that makes sense though because it's a comment and they should be able to comment. Right. They can comment, but nobody's going to respond. So I don't know how to do this. Let me go up. No, that's why I asked. Isn't it? Aren't you glad that I informed you of that? Because without it, I would die. I'm probably going to fall asleep if I don't know. So I'm not right now. It's just military energy gel. There's multiple flavors. Rainforest got you. Chewable red. Basically. It's better because it goes sublingually rather than through your digestive system. Much more effective. I want to check them out. Yeah, well, I just want to so that I can put things in context and figure out what's going on. Okay. And a comment. Okay. I'm typing one right now for him to get started. So one from James Walker here. I'm typing it to him so he can read that off his phone and then start to see. Does that make sense? Okay, goodbye. Well, I said. Got it. Yes, I got it. I can do it. I got it. I got it. Very last slide. Here's the printed version.
Thank you, Mitch. Yeah. Because I don't think this one, this one doesn't, is it on? Can you hear me? So you can hear me through that. Okay. So, oh, you're going to have it up on the screen? Okay.
Running it in the back.
Okay. If we could have people start taking their seats. If we could have people start taking their seats. Can you hear it? Can you hear it all? I can't. If we could have people take their seats. Okay. We're going to get started with the public comment section. So for the public comment section, due to the nature of this webinar and the number of participants, I am actually going to have to read the public comments coming in. So please know that if you are online and submitting comments, we will be reading them aloud and announcing your name as well. After we make it through the online comments, then we will have a microphone for folks to queue up in the room, and we'll do public comment from the room at that point. So the first comment today comes to us from James Walker. He had submitted this as a question earlier as well, but he wanted to resubmit as a public comment. Can the panel comment on the concept of requiring hard tokens, such as chip-laden ID cards, as requisite to access of disparate silo e-personal health information? The use of hard tokens plus user ID, password credentials could probably be the threshold beyond which the patients and the providers would in unison advocate for widespread participation in health information exchange, especially if bolstered by a fourth factor. For example, both the provider and patient concurrently utilizing hard tokens in the same workstation whenever personal health information is accessed across disparate systems. That's coming from J. Stephen Walker, MD, Family Medicine, Corpus Christi, Texas. Next is from Michael Martz. For providers and patients, trusted exchange does not exist in a useful way because of the incompatibilities between multiple networks, both for data and for trust, that too many of us have to straddle. And two, because we have not fully created solid standards based on consistent use cases, which prevents our EHRs and personal apps from being broadly able to ingest and fully use the data in a constructive form. Networking compatibility is not just a problem for 10% of interoperability, it's a problem even for local interoperability when exchange is needed between a geographic HIE and a vendor-sponsored network like CareQuality. Only when these are fully solved will we be able to have reliable interoperability locally and nationally. Next comment comes from Scott Stewie, independent consultant representing multiple clients. My question is the expectation of the framework to be developed that it would be the only agreement that would need to be executed by an endpoint. If so, how will the framework adjust to new use cases, particularly those that relate to unique capabilities of one or a very few of the initiatives and interoperability required to enable them across networks? Next comment is from Adrian Groper, patient privacy rights. Should all exchanges that include HIPAA-covered entities be required to allow patients? HIPAA-covered entities themselves must allow such access. Next comment is from Mark Savage. Two questions from a consumer perspective. Are individuals, consumers, patients directly represented? Next comment from John Birch. How many online attendees are there? And at 2:26 p.m., the answer to that was 463. Mark Savage came back with another comment. Are individuals and patients part of your governance process? Can consumers and patients request their data through your system? And that looks like that is all we have at this moment from the online comments that I'm seeing. If you have a public comment, you're participating on the webinar. If you want to share it through the chat feature, we'll be glad to read that out. In the meantime, we will take public comment from the room. Mitch.
Oh, I'm so sorry.
Thanks. My name is Sasha Tremont, and I'm the chair of the Electronic Health Records Association. And I know myself and many of the other members of the Electronic Health Records Association were very eager to learn about the direction that's being taken with this kickoff. I think we have two considerations to urge on the group as we think further about what direction to go. We'd really like to see that all of the technical investments that have been made over the last few years in the standards that we've heard a lot about earlier today continue to be leveraged and taken advantage of, given the amount of intellectual capacity and financial investment that have already been given to those standards over the last couple of years. Similarly, a lot of us have put a lot of effort into many of the networks that we've heard from earlier today, other networks who maybe aren't here to be represented. And I think that the investments made in those initiatives to connect and to provide governance and trust are also going to be critical to take advantage of as we look to the common agreement that's being worked on today. Thank you.
I'm John Gerd. I represent long-term post-acute care, and I cannot let it go by without saying a couple things about long-term post-acute care and longitudinal care, and that we are exchanging. I'm working with one vendor now, Matrix Care, that's exchanging 300,000 exchanges every day electronically. We are still having problems with the patients getting to our nursing homes at 4:30 on Friday afternoon with a paper record on a Guernsey, getting the electronic record on Tuesday where it's irrelevant to us. And we still, on the trust issue, we have a problem with to forward electronic EHRs to the ER and with a CCD or CCDA, and they say we don't trust the information coming from you. All the vendors are really certified, and that, so we're having a little educational problem, and I only speak up because so many times we get blasted as not being the one. It's really a business case, as David said up there. If you have a business case, we can exchange information electronically.
Raj Sharma from HealthWiz. As a patient, what kind of assurances any of these trusted frameworks can give about two things? One, that you're taking enough precautions to getting my data hacked and stolen from your servers. And number two, what assurance can you give that you're not going to turn around and sell my data, even if it is de-identified, that you're not going to sell that data to data brokers because your business model requires that, or for a number of other reasons. So those are the two things that I, as a consumer, would like to know.
Mitch? Yeah. Oh, I'm sorry.
All right. Thanks, Lee. Diane Jones, American Hospital Association. First of all, thank you to ONC for convening this group of stakeholders. You certainly have the power to convene all the stakeholders, and as I've been listening, I've been very impressed with the diversity of exchange activities that are underway. And thank you for the report that looked at those varying organizations. With that said, I have to also note, though, that as we all think about information exchange and interoperability from our own perspectives, the providers are looking at the business need to exchange information to support the care of the patient who's in front of them, to support smooth coordination of care with others in that care team, to engage the patients in their own health and wellness vis-a-vis giving them that information. I would just urge you to prioritize, as you can prioritize, that particular use case that's right in front of us right now. And that business model does exist, as I think some were concerned about whether or not the business model is there. And leverage the existing activities that are already well underway, multi-stakeholder activities. I heard a number of examples where groups are working together collaboratively right now. So certainly look to that. We will certainly comment on that, and thank you again.
Good afternoon. My name is Ben Moskovich. I manage health information technology initiatives at the Pew Charitable Trust. Pew is a large nonpartisan, nonprofit public policy and research organization. Our health IT work focuses on two issues, the safety and usability of electronic health records and advancing EHR interoperability. Today's discussion on trusted information exchange and common agreement provisions seek to advance a common goal, interoperability of patients' health information. Under this vision, as spelled out by Congress in the 21st Century Cures Act, an interoperable health system would enable the secure exchange of patients' health data among healthcare providers and ensure the electronic access, exchange, and use of the data for authorized users. That vision relies on two critical issues being addressed. One, patient matching, and two, challenges with data standardization. Patient matching is the ability to link a patient to their health records held at multiple locations. And researchers have found that match rates can be as low as 50% when matching across institutions. As a result, patients and their doctors and other providers may lack critical data to inform care decisions due to the inability to link an individual with their health records. Pew is conducting research to better understand challenges with patient matching and evaluate solutions to fix this problem. For example, we're conducting focus groups with patients to understand how they view patient matching and their perspectives on biometrics and other identifiers. We're also examining whether patients can be in charge of matching their records and whether more robust standards for demographic data, such as name and date of birth, could help enhance match rates. Second, standards for clinical data elements, such as test results, can also affect interoperability. Under this standards challenge, one health IT system may document information in a certain way, but receive that data from another system in a different manner. In this scenario, the receiving system may not know how to process or code the data, which could result in it being dropped or turned into information that can't be used for clinical decision support, such as to provide a graph of the patient's blood values over time. At Pew, we're also examining this challenge and documenting how it can inhibit interoperability. We're also examining different solutions, including those on which the private sector can take the lead to help address this challenge. As ONC and everyone here today seeks to advance network-to-network exchange of health data, we urge you to consider the importance of patient matching and data standards, and we'd be happy to serve as a resource as we further conduct research in this area. Thank you for your time.
Thank you. Let me go back and catch up a little bit online because we are starting to get a few more in, then we'll return to the room. So from John Birch, wanted to pose the question, what are these exchanges doing about the erroneous clinical data in EMRs? Peter Bachman wrote in, using a common denominator applies to all U.S. persons as already defined and has to additionally apply to the 500 plus Maria Lopez in LA using the same social security number. Bill Myers, Vibra Healthcare. Is anything being done to engage healthcare entities that were not included in meaningful use? Being a long-term acute care organization is very difficult with all of the payment reforms to fund this technology associated with this technology. The onboarding costs are in some cases very high. Daniel Escobar, how to reconcile all the multiple rules and regulations that do not align and often conflict with each other. For example, HIPAA 42 Part 2, FERPA, FTI requirements, child support, SSN, SNAP programs, MARS, exchange requirements. All these involve providing services to people with challenges involving coordination. George Fenton, Washington County ITS in Oregon. If a provider is considered non-compliant, what will the sanctions look like against the provider? Could the provider be multi-sanctioned by OCR, ONC, and the FTC under a 21st Century Act violation? Steve Waldron. I am with the American Academy of Family Physicians. My comment stems from an agile perspective. While it would be great for the Common Trust Framework and Agreement to include all that was mentioned in the Q&A and panel discussions today, I fear that such a scope will never be finished as an adoptable framework. I believe we should identify what is the minimum viable Common National Trust Framework Agreement and could be achieved rapidly, and then establish a process and community to iterate its expansion. I think this is especially the case given the large volume of work by the current trust organizations that were represented today. Adrian Groper, patient privacy rights. I note that 21st Century Cures mentions longitudinal health records, but no mention of such was done today. Who should be responsible for solving this problem? We will return to the room for additional public comment.
Yeah, hi, this is David Kibbe. I'm the president and CEO of Direct Trust, but I'm going to speak, make some comments that are based as much as my experience as a family physician using electronic health records and a public servant working on standards and working for the American Academy of Family Physicians with my colleague, Steve Waldron, who just commented. I'm going to make a case for management and maintenance, because I think that one of the things we want to understand here and take into consideration is that we've been through a 5-year experience, maybe 6-year experience, in which, in a sort of a lightning way, virtually every hospital and every medical practice in this country has adopted and is using electronic health records. And yet our expectations about that are extremely high. I think we should understand that this is an experiment that's still ongoing, that the products, the electronic health record products that are in use today by somewhere in the neighborhood of 90% of all hospitals and at least 80% of most medical practices, probably 75 to 80%. These are imperfect products. These are products that are still working out fixes to bugs and to problems that will take another 5 years for them to really fully work out. The more demand we put on these electronic health records and the vendors to adopt new standards, for example, to upgrade their systems, the harder it gets for us to focus on the maintenance of the systems that work. And I think that one of the things that we're not paying enough attention to in this conversation, although it's there, we're just not, and that's why I'm speaking to it, is that any trust framework that works to support large-scale health information exchange requires a lot of maintenance. It requires a lot of operational work. It's a dynamic system, and I don't think we want to create some new, unnecessary, disruptive kinds of elements to this. The lady who spoke about them from the American Hospital Association, I agree with your perspective. We really need to make sure that we focus on what works, making it better, and working out the bugs in our health information exchange and our health information exchange trust frameworks. Thanks.
Hi, this is Deborah Green of the American Health Information Management Association, and I'd like to thank the ONC and for all the speakers on behalf of the frameworks today here. It's been a very fruitful discussion so far. We believe that the Trusted Exchange Framework and the related agreements, we believe it's very important that there be bilateral accountability in the agreements so that both parties are required to institute and maintain data and information governance, because that will enable us to not only trust the exchange, but to trust the data and the information that we are obtaining through the exchange, and know that we can rely upon it. Thank you.
Hi, this is Panya Cheng, CEO of Medyear. Thank you to ONC for putting together this forum. As a technology company, we operate in the nascent area of identity proofing, and one of the areas we would hope the ONC and the government will pay some attention to is the use of artificial intelligence in identity proofing. It's inevitable that companies like ours will use AI to scale how they do identity proofing, but we would love to see some thought given to how an AI should be deployed and the proper role of AI for identity proofing. Thank you.
It appears we have no further comment online. One more maybe in the room.
Hi, Carol Robinson, Cedar Bridge Group, LLC. One of the things that I was thinking about when Dr. Kibbe was talking about maintenance, and I don't disagree, but I also think that what we haven't really talked about are two things that I've heard today. One being that there's a lot of trust agreements that are also being done in governance at state level. And so thinking about collecting information on what's happening at the state level as well, and bringing the states in to make sure that if there is going to be a federal solution, that it doesn't become completely incompatible, or at least the states can plan for whatever alterations that they may need to do so, because it could be legislative changes as well. And then the second really is around supply and demand of information and information exchange. And so until there's really, the acceleration of new payment models that drives the need and desire to exchange information, the entities that we're trying to create trust between and around are not necessarily motivated to become as interoperable as we'd like them to be. And then the second piece is their vendors then aren't hearing from them that they would like for their products to become more interoperable. I think as soon as their customers really want their products to be more interoperable and their customers are demanding that, that'll happen. So those were my comments.
I think there's one more right there, sorry.
John Doerr again. I've been working on the ELTSS project, and I went to the American Society of Aging, and where there was about 1,000 or 2,000 people there, all on social issues. And also they talked about LTSS a lot and home-based care. And none of them knew about the electronic long-term services and support program. Most of everything was on paper. And my point is there's a lot of agencies doing a lot of things. I'm also on a grant for the RAND Corporation for Reconciliation of Medication. And that's a big issue, is medication reconciliation. And I don't think everyone's talking to everybody else. And I don't even know, I keep hearing out of scope and different things like that. And I would hope, sir, Don, can look at all of the things, and you guys help him out to look at the whole big picture, because it's not being looked at. I see in all the meetings, I got 80,000 air miles already this year, still going around to everyone out in the field and that. So I just want to emphasize that. Plus, longitudinal care, which somebody mentioned, is very important to get out of this episodic environment into where we can really do trending. And I'm on the patient engagement task force, and I keep bringing up all the time, we have to talk about trending, and that static information doesn't help anything at all. And we have to talk about aggregating. I'm a chronic care patient, and I have about 5 different conditions. They all have to be aggregated and looked at with clinical decision support software. Otherwise, taking one quality measure of one of my things is not going to be any good. And I'm mostly talking about elderly people and chronic care patients, which costs us a lot of money.
We've had an additional comment come in online from Michael Mover. Most of the issues discussed today have been discussed for years with little ability to make substantive progress on interoperability, positive identification of patients, or security. I would suggest that we need specific measurable timelines that lead to the future we want. In order to deliver that, we need to have the following. 1, we need to have a highly reliable method of uniquely identifying a patient. 2, we need a legal framework that allows for us to exchange information without fear that our partners will behave in ways that put us at risk. 3, we need EHR and medical device vendors to show real commitment to timelines for delivering on interoperability in months, not years. 4, EHR and medical device vendors need to understand that security and reliability should not be a competitive advantage, but simply a minimum expectation. An additional comment online from Kathleen Johnson. I'm encouraged by the innovations discussed here today. I see potential for the inclusion of student health data that exists in our nation's K-12 system, particularly to meet the patient's right to have their data shared with their school nurse. What kind of support is available to support, at best, true interoperability with K-12 health documentation systems, and at a minimum, a CCD that is created in an EHR and includes demographic information, summary of the care event, medications, recommendations for school care with an embedded release of information that could be approved by the parent at the time of care. The CCD could then be transmitted. We mostly rely on fax in schools to the school nurse. That appears to be our final online comment. There are no additional comments in the room. Well, one additional online comment from Daniel Escabel. How to address the collective action problem of establishing a common ecosystem when grants and awards often target a specific area of care, but don't allow for any investment into common solutions that benefit everyone. And with that, we will end the public comment section of the meeting. I would like to next invite up our new Principal Deputy National Coordinator, Genevieve Morris. And right after Genevieve, Lauren Ritchie, who many of you know from ONC, will be coming up to talk about how you can go on the record using our JIRA system at ONC starting tomorrow. Thank you.